Pharmacology SAQ 20 Renal Drug Handling. A. How does the kidney excrete drugs? Processes involved includes filtration at the glomerulus, secretion at the proximal convoluted tubules, and diffusion and reabsorption at the distal tubules. Filtration at the glomerulus. Small non-protein bound, poorly lipid-soluble but readily water-soluble drugs are excreted into the glomerular ultrafiltrate. The rate of drug filtration is increased by increased GFR, reduced drug size. The drug has to be less than molecular weight of 60,000 daltons or less than 30 angstrom to be filtered. Positively charged molecules are filtered more than neutral charged molecules, which are filtered more than negatively charged molecules. Reduced protein binding. Only free drug present in that fraction of plasma may be filtered. Thus, highly protein-bound drugs are not extensively removed by filtration. Drugs not incorporated in RBCs, an increased number of functioning nephrons increases the rate of drug filtration. If renal clearance equals GFR, then it is a drug with low renal extraction. The next process is secretion at the proximal convoluted tubules. This is an active energy requiring process that occurs in the PCT via active carrier transport mechanism, by which a wide variety of molecules may be secreted into the urine against their concentration gradients. It is dependent on renal blood flow, independent of protein binding. Even bound drugs can be stripped of plasma proteins in one pass of the blood through the kidney. It is the most effective mechanism for drug elimination. This process is able to excrete larger molecules. Different carrier systems exist for acidic and basic drugs that are each capacity limited for their respective drug types, i.e. it is a saturable transport system. Acidic drugs may compete with other acidic drugs for tubular secretion. Examples of acidic drugs include penicillins, cephalosporins, salicylates, thiazides, and furosemide. Basic drugs may interfere with elimination of other bases or cations. Example of basic drugs includes morphine, neostigmine, and lidocaine. Maximal clearance of one acidic drug will result in a reduced clearance of another acidic drug, but not of a basic drug. Drug secretion may be inhibited. For example, probenecid blocks the secretion of penicillin. Drugs with renal clearance more than GFR is cleared by active secretion. Increased active secretion enables renal clearance of a drug to approach effective renal plasma flow. The next process is diffusion and reabsorption at the distal tubules. Drugs which are present in the glomerular filtrate can be reabsorbed in the distal tubules. At the distal tubule, passive diffusion may occur down the concentration gradient, and the rate of diffusion obeys fixed law of diffusion. The amount of drug cleared by diffusion or reabsorption is dependent on urine pH, drug ionization, flow rate through the tubules, drug concentration, and drug lipid solubility. Urine pH determines non-ionized fraction in the urine. The urine here is normally acidic but can range from pH 4.5 to 8.0. Drug ionization. If a drug is unionized, it may be readily reabsorbed. Acidic drugs are preferentially excreted in an alkaline urine, as this increases the fraction present in ionized form, which cannot be reabsorbed. Examples of acidic drugs with urine pH-dependent elimination includes phenobarbital, salicylates, and sulfonamide derivatives. Conversely, basic drugs are preferentially excreted in acidic urine, where they are trapped as cations. Examples of basic drugs with urine pH-dependent elimination includes amphetamine, ephedrine, and quinine. Flow rate through the tubules determines transit time and concentration gradient developed in the tubules. Drug concentration. Much of the water in the filtrate has been reabsorbed, and therefore the concentration gradient is now in the direction of drug reabsorption. Lipid solubility. The membrane is readily permeable to lipids, so filtered lipid-soluble substances are extensively reabsorbed. If drugs are extensively reabsorbed in the distal tubules, then renal clearance of that drug is much less than GFR and may have almost no renal clearance, i.e. very low renal extraction. Magnitude of renal drug clearance equals the sum of glomerular filtration and active excretion minus renal drug reabsorption. Examples of drugs with low renal extraction includes furosemide, gentamicin, and digoxin. Example of drugs with high renal extraction includes para-aminohippuric acid, salicylic, probenecid, penicillin, morphine, atropine, phenylbutazone, sulfonamide, indomethacin, glucuronide, sulfates, histamine, procaine, procainamide, and tolazolone. B. How might chronic renal failure affect drug handling? Drug absorption. If via oral route, uremia delays gastric emptying, increasing risk of dose stacking, such as in oral metoprolol. Drug bioavailability may be increased by decreased enzymatic metabolism due to uremia. Urea inhibits CYP3A4 and P-glycoprotein efflux pump. For inhaled drugs, there may be increased uptake of volatile anesthetic if there is increased minute ventilation due to metabolic acidosis caused by CKD. Drug uptake via inhaled route may reduce if there is increased diffusion distance caused by pulmonary edema. For drugs administered via subcut, IM, or topical, increased total body water leads to edema, which increases diffusion distance, and this reduces rate of absorption and onset. If cardiorenal syndrome is present, reduced blood flow leads to reduced drug onset. There is risk of dose stacking, for example for GTN patch and IM ephedrine. Drug distribution. CKD causes increased ECF volume, which increases volume of distribution of water-soluble drugs. There may be a need to increase loading dose to achieve target plasma concentration. Example of water-soluble drug is succinylmetonium. If metabolic acidosis is present, this increases unionized fraction of acidic drugs such as thiopenton, leading to increased thiopenton effects. Metabolic acidosis reduces unionized fraction of basic drugs such as morphine, leading to reduced morphine effects. Plasma protein concentration. Albumin concentration reduces in CKD. This increases free acidic drugs such as diazepam to increase its effects. Alpha acid glycoprotein increases in CKD. This reduces free basic drugs such as morphine, leading to reduced morphine effects. Drug metabolism. Urea inhibits CYP enzymes, such as that in the liver. Hence, drugs such as fentanyl, which are cleared by CYP enzymes, have increased duration of action. If hepatorenal syndrome is present, this reduces hepatic drug clearance. Reduced renal drug metabolism leads to increased duration of action of drugs inactivated by kidneys, such as insulin. Drug excretion. Renal drug clearance is proportional to GFR, and renal drug clearance reduces with worsening GFR. If parent drug is renally excreted, such as pancuronium, there will be increased duration of action, hence preference for atracurium in CKD. If active metabolite is renally excreted, such as morphine 6-glucuronide, this leads to opioid toxicity, hence preference for fentanyl in CKD, which does not have active metabolites. If toxic metabolite is renally excreted, this may increase toxicity, such as norpetidine, leading to seizure, hence preference for fentanyl in CKD. Hemodialysis. There is variable drug clearance by hemodialysis. Small unbound particles are cleared by hemodialysis, hence administer after dialysis. Large protein-bound drugs are unaffected, hence dosing schedule is unchanged. Hemodialysis causes normalization of total body water. This reduces volume of distribution of water-soluble drugs and potentially increases their plasma concentration. Overall implications of CKD. There is disturbance of all aspects of pharmacokinetics, leading to unpredictable drug behavior. Titrate to effect. Consider reduction of dose and frequency. Risk factors of drug toxicity in CKD include severe reduction in GFR, renal clearance of parent or active metabolite, and low therapeutic index. When total body clearance of a drug is predominantly carried out by renal excretion, i.e. when renal clearance exceeds 0.7 of total clearance, then drug accumulation will occur in renal failure. Examples of these drugs include aminoglycosides, chlorpropamide, digoxin, alkyronium, galamine, D-tubocurarine, and pancuronium. Therefore, there is a need to decrease maintenance dose or frequency of dosing of these drugs. When renal clearance contributes to less than 30% of total clearance, renal disease will have little effect on drug elimination. Thank you.